It's a active simulator that's just going through heartbeat after heartbeat, doing a whole series of calculations that are based on representations of the cardiovascular system. The panels to the left, your left, are the inputs to the simulation. So we'll be able to go in there and change some of these numbers and then see what happens. The panel to the far right is the output numbers. And there are two columns there. In the green are numbers that I have stored. So they're locked and they're not going to change. Next to it are the live numbers. So that if I make a change on the inputs to the simulation, the live numbers will change and we'll be able to compare them to where we started in the green. And then in the center, of course, is all the graphics, which should look a lot like that first couple of slides that I put up. You see the pressure traces here, aortic and ventricular. And then above the corresponding pressure volume loop, and you see the bouncing ball going around. Each goes around once each heartbeat. The end systolic pressure volume boundary and the end diastolic. All right? So we're talking about contractility. So let's make a change in contractility and see what happens. Okay? Now, it's a simulation, so I have a way, actually, of just numerically going in and changing the contractility number. Okay? You see an input there labeled contractility. It has a number of 2.21, but I'll decrease it. Okay? So I'm going to hit the minus button, and I'm going to decrease contractility. What's happening to the end systolic relationship? The slope went down, right? So you see here in green where the PV loop where we started, and red where it is now with the new contractility. So what happened to the hemodynamics? What are some of the key changes that you see? Cardiac output is lower, EF is lower. Systolic aortic pressure is lower. Diastolic a little bit, the mean. This is the MAP, right? Went down. So we see reductions in pressure of the patient, reductions in cardiac output, and a reduction in EF. So all of those, you know, we could have just ascertained by looking at the PV loop. The PV loop, the new loop is shorter, right? And the height of the loop is related to peak pressure, right? So we're seeing a lower pressure patient. The width of the loop is stroke volume. Stroke volume is related to cardiac output, right? Less, and it's a narrower loop. So stroke volume went down, i.e. cardiac output went down. And then EF is the stroke volume divided by the end diastolic volume. The end diastolic volume, although you see a slight change there, it's not much. So the stroke volume reduction led to an EF reduction, all right? So that's a change in contractility that we just did mathematically, purely changing the numbers in the simulation, all right? But as we said before, I'm just going to go back to the beginning where we started. As we said before, clinically, the way contractility is often changed is people have an MI, right? Actually, let me go back to that patient and give them an MI. So we've reduced contractility with a big heart attack. They're having an infarct. Their pressure's down, their cardiac output's down, and the physician now is going to react to that. They're going to react probably to the low pressure, and they're going to want to get the patient's pressure up. So one typical thing they'll do is give them inotropes, right? So we have here another input panel where we can actually simulate certain drugs to this patient. For simplicity's sake, I'm just going to use dobutamine. And I'm going to give this patient some dobutamine, right? What would I expect to happen? Right? We would expect the slope of that end systolic pressure-volume relationship to go back up and start looking more like this green, the original PV loop. So let me give them a little bit of dobutamine and see what happens. Okay. That's just about back to the original slope, right? But let me clear that. Did we get back to the green loop? No, something else changed when I gave him dobutamine. What happened? Look at the heart rate. So, did I achieve the goal as a physician I was trying to achieve? In part I did, right? If I was just thinking, I got to get this patient's pressure back up, right? We got the contractility back up. Did the pressure go up? Yeah. Went up even higher than we started, right? But it went up higher than we started because of that heart rate effect, right? There's an inherent heart rate effect. So the point I want to make is that in the real world, although we do things, with drugs to sort of change contractility, no drug is a pure inotrope, right? It's not a pure changer of contractility. It does that in addition to other things. And you'll see, in particular with a lot of the drugs that patients get to affect their hemodynamics, there is this heart rate effect, this chronotropic effect, which changes the PV loop, and as we'll get to later, it changes the overall energetics of the heart and makes the heart work harder. But in general, when we changed heart rate, what happened to that loop? Narrowed and got taller, right? That's a common representation of a heart rate change in the PV loop. So the stroke volume went down, so you're sacrificing some stroke volume to get pressure, okay?